All right, Dr. J. We're going to come back now for anybody who's coming back from the break. I think we'll get started with our final presentation here by the fabulous Dr. Minas Joannides, who is our Chief Medical Director at Optimum here in the Dallas office, and obviously for our entire company. He started in private practice in pulmonary medicine in St. Petersburg, Florida. Both grandfathers and his father were pulmonary specialists, so it runs in the family, and has worked at 3 different direct life companies before coming to Optimum Re. And a few fun facts about Dr. Joannides. Spring training bat boy at the St. Louis Cardinals in St. Petersburg, Florida. He got to pilot the MetLife blimp over Tampa, Florida, and he studies Greek and Roman architecture. So great to have you, obviously, always, Dr. J, and looking forward to this presentation. And again, everybody, please hold the questions towards the end if you can. You can ask them during and we'll collect them, and then we'll save some time at the end to answer those.
Well, thanks, TJ. I'm still fighting a little bit of bronchitis, so my voice is a little off, but I'll try to do the best I can. Hopefully you can tolerate that. So today we're going to change gears a little bit. We've heard from Dr. Green about psychiatric issues, and we've heard about psychedelic drugs. So there's not much psych in this one. We're going to talk about underwriting thyroid nodules, but we're going to kind of approach it from a different perspective. So for the 163 participants that have hung in there, I appreciate it. So let's get started, okay? So today we're going to think a little differently. Instead of going vertically, we may go horizontal. Here's a fellow who decided instead of growing his tree up, he would go sideways. And so he has a nice little seat to sit on underneath the tree, and he's just thinking differently. This was actually used in an old Apple ad many, many years ago. So picture I took in Northern California. I think people think a little different up there. So today we're going to talk about thyroid nodules, and we're going to talk about unraveling the diagnostic puzzle, because we see a lot of these in the applicants that come in, right? The APSs that we see. Somebody may have either an incidental finding or on palpation, somebody finds a lump in somebody's thyroid, or maybe one or more nodules. So, things that we would like to know, is there any history of external radiation that they might have encountered? Do we have any idea whether these might be benign or malignant? Probably all we know is that there's a nodule there. We may not have a biopsy, or the biopsy that was done may be inconclusive. So that's not a big help. So what do? Do I postpone for a biopsy or surgery, or can I accept now and rate it? So how are we going to make these decisions? So today I'm going to talk about the equalizer, and hopefully something that helps you maybe get a better decision-making array of ideas that will help you in your decision. So the anatomy of the thyroid, it wraps around the trachea, and the right and left lobes are connected by an isthmus. And on the back side of the thyroid gland are 4 parathyroid glands. So often, if somebody has a thyroidectomy, the surgeon may have taken one or more of the parathyroid glands out by mistake. So you may see that in the pathology report. So we know where the thyroid is located. And there's a feedback loop, which involves the hypothalamus, which is right below the thalamus in the brain. So that's why it's called the hypothalamus, which secretes thyrotropin releasing hormone, or TRH, which affects the pituitary, which releases TSH, which affects the thyroid. And then the thyroid releases thyroid hormone, and the level of thyroid hormone in the blood feeds back to both the hypothalamus and pituitary. So you have a nice feedback loop of these 3 organs. And the TRH has not been known that long. It was actually found in the 1960s, and the doctor that worked on it won a Nobel Prize for finding TRH in the hypothalamus. He used pigs as his research and found that that was present. He was actually at the Veterans Hospital in New Orleans, and he was still working there when I did my medical rounds at the VA when I was in med school at Tulane Med School. So it hasn't been that long ago that TRH was found. So I talked about, has the person that you're considering ever been exposed to external radiation? And you may be aware that the Chernobyl reactor, there was a disaster in 1986. So people that were born in Europe and lived there in 1986 may have had an exposure. And you can see how large the radiation cloud was back then. It engulfed basically the entirety of Europe. So there may be people that are exposed to radiation accidents, or they may have received medical treatments with radiation and had exposure to their neck. So is there any history of external radiation in the cases that we see? And actually, we've seen two big cases at Optimum where I don't even know if the applicants were aware that they were living in the Chernobyl cloud zone when they were young kids. Also, back in the 1950s, when there was a polio epidemic and kids were not, their parents didn't want them to be admitted to the hospital where other people had polio. They may have been treated as an outpatient with radiation to their tonsils, which we would find horrendous at this day and age, but those are the kinds of things that went on when nothing else was available. So at Optimum, we have guidelines for what do we do with a thyroid nodule. And as you can see, they're lengthy and complex. And I refer to these, but I thought maybe there was a better way that I could develop that actually used the TIRADS system, which is, as you may know, is often noted in the APSs on radiology reports. So that's why I've developed this talk, to kind of assist any guidelines that you may have or that we may have on what are factors that we could use to help us out. So a lot of times we hope to get a fine needle aspirate of a nodule in the thyroid. And this is done under with ultrasound guidance. So you try to stick the needle into the nodule, aspirate, and hopefully get cells that will help you diagnose what the nodule is. However, not being a pathologist, you may find this slide as complex as I do, and it's hard for me to tell which are the more benign and which are the more malignant slides. So obviously we have to rely on a pathologist to help us out with the fine needle aspirate cytology to see which side of the ledger. And there's a lot of in-betweeners that aren't really called benign, and they're not really called malignant, and they may not be helpful to us when we're trying to figure out, is this biopsy that somebody had of a nodule or more than one nodule, is it really helpful to us? So it can be confusing as well. And a lot of times the biopsy is non-diagnostic. So that doesn't help us. So sometimes these, I consider them of dubious value. Unless you get a clear-cut answer, it's hard to know what to do with a non-diagnostic cytology report. However, if somebody has a highly suspicious TIRADS nodule, and we're going to talk about that, even if they have a negative or non-diagnostic fine needle aspirate, you may have a lot of concern about what is that nodule, if it meets the most highly suspicious characteristics of TIRADS 5, and we're going to talk all about TIRADS. So what does TIRAD stand for? Thyroid Imaging, Reporting, and Data Systems. So our manual doesn't use TIRAD's nomenclature yet, but the APSs that we see often do use TIRAD's descriptions of thyroid nodules. So that's why we're going to talk about it today, to help you solve the dilemma when you see a nodule in an APS on an applicant that you're underwriting. So the American College of Radiology first started this classification in 2017. So hopefully cases that we see where the APS includes an ultrasound after 2017 of the thyroid will help us with what TIRAD's risk level is apparent in that particular nodule. And so you can see that TIRAD's 1 is the most benign with a low risk of malignancy, and TIRAD's 5, which is considered highly suspicious of malignancy, has a much greater risk. In this case, the ACR, or the American College of Radiology, says it's approximately 35%. So that would be a highly suspicious risk, right? There's also European TIRADs. They went slightly differently, and their scale is slightly different, and they consider TIRAD's 5 as a much higher risk, with the malignancy risk between 26 and 87%. They also included some comments in each of these categories that I'll just mention. We're going to talk more about them. But on the, say that for the TIRAD's 2, which is on the more benign side, if the nodule was cystic or described as spongiform, like a sponge, those were benign characteristics. And you can see the TIRAD's 5, or high risk categories, I've highlighted in yellow the things that are the riskiest features of a nodule. And that would be an irregular shape or irregular margins, microcalcifications, or what's called marked hypoechogenicity. And we're going to talk all about that. If the nodule is solid, that's also a high risk feature. So we're going to talk more about these, but I just wanted to let you know that the US and the European Union have slightly different risk percentages for each of these categories. So we're going to do a little critical thinking. You know, you can't have a talk these days without talking about critical thinking, right? So is there another way we can kind of put this together? And the way my mind works is whenever I see a problem, I try to break it into the concepts so that I can simplify it. So I take what I see to start with, break it into the concepts, and then put it into a simplified plan. So we're going to call that the equalizer. So I'm borrowing from some movies and TV shows here. So we'll take this noise, all about all these features of what the thyroid nodule may be described as, and try to turn it in to an effective signal that you can use. So we're going to talk about what are the probabilities of malignancy when we see a nodule. So we're going to play the probabilities game. Each nodule, and some people have many nodules when they have an ultrasound done, carries its own unique risk. So the radiologists are actually taught, when they describe the nodules in a ultrasound report, to only rank the 4 most suspicious nodules. So if the applicant has 7 nodules, the radiologist may only comment on 4 of the 7. And hopefully those that helps you out, but you may still have questions about what's going on with the other 3. what we want to address are what are the most adverse characteristics of a nodule. And then again, is there any worrisome family history or external radiation exposure that we should be aware of? So here's the good news. When we take a chance on a case where there's a thyroid nodule, even if it's later diagnosed as thyroid cancer, the 5-year survival of thyroid cancer is very good, as you probably already know, 98%. So, that's good. So even if we make an offer rather than postpone or decline, probability-wise, if we rate some of the less worrisome nodules, we probably come out just fine. So that's why we're going to try to approach this from a risk standpoint of maybe I can take some nodules that I might in the past otherwise have passed on. So what are the things that we want to watch out for, though? What are the adverse features that are the highest risk characteristics? And that would be a larger size nodule, and we'll talk about size in a bit. If there's any micro calcifications, that would actually be worse than like calcification around the edges or something like that. But if there are dots of micro calcifications, also described as punctate calcifications, that's high risk. If the lesion is taller than it is wide, it doesn't seem like that would contribute to an adverse feature, but it does. So if the nodule is taller than wide, that's adverse. If there's any evidence that there's extra thyroid invasion, so it's outside of the nodule into the thyroid and then further out, that's negative. If they happen to see an abnormal lymph node, or if it's described as hypoechoic or hypoechoes, or very hypoechoic, and we're going to talk about those terms. And then if it's solid rather than cystic. So if a nodule has any of these characteristics, that's adverse. So we would be, red flag those. So today we're going to have you be radiologists for the day, and you get to charge the same outrageous rates that the radiologist charges for reviewing the ultrasound. So I don't know whether you can see this or not, but these are actual ultrasound pictures from the Thyroid Association. This was written up in the magazine Thyroid, and perhaps you can actually read what some of the pictures actually have in type at the bottom of each one. And you can see at the top we have the highly suspicious lesions where the risk of malignancy is 70 to 90%. And like the first box to the far left on top has little punctate white spots, which are micro calcifications. So as I mentioned before, that's high risk. Other features in the pictures are irregular margins. In the third picture at the top, it's taller than it is wide. That's bad. If you go to the bottom where it says benign or less than 1%, you can see it's just looks like a black hole. That's actually a cyst. So that would be on the benign side. Right above that, what's called spongiform, or the very low suspicion, less than 3%, kind of looks like a sponge, right? So you can kind of start getting an idea on what are the bad features and what are the more benign features. So, as I said, today you're going to be a radiologist. And here are the 5 characteristics that we're going to look at. And it is composition, echogenicity, or what kind of echoes are in play, the shape, the margin, and the echogenic foci, which is talking about calcification. So it's CES, ME. And those are the 5 indicators in TIRADS. Okay. So this slide is super key to your understanding if you really want to know the background of how TIRADS actually works. Okay. So at the top in red, I've put a red border around those 5 indicators, which include the composition of the nodule, the echogenicity, the shape, the margin, and the echogenic foci. So it's detailed here, but this is really the key to kind of understanding what TIRADS is all about and how risky is any particular nodule. So each of those 5 boxes has points according to what characteristics are present for composition, echogenicity, shape, margin, and foci. Okay. Below that, in green, in the green box, I have the 5 TIRAD risk groups. And they're, instead of TIRADS, they just use TR1, TR2, TR3, TR4, and TR5. And so you distribute the nodules, if you're a radiologist looking at an ultrasound, by how many points are accumulated from those 5 boxes at the top. You add up the points, and then you get to what TIRADS group that belongs in. In addition, in the green box, if you'll notice, TIRADS 3 has 3 points, but if you look at where it says mildly suspicious, it depends also on what is the size of the nodule. And it's in very tiny print, but hopefully you can see it. It says FNA if greater than or equal to 2.5 centimeters, meaning that would need a fine needle aspirate if it's greater than that size. If it's between 1.5 and 2.4, it would just follow up. Same with TR4 or TIRADS 4 is 4 to 6 points, and TIRADS 5 is 7 or more points. So for each of those groups, you accumulate points. So I hope everybody's kind of following with me here, and they're kind of getting how this TIRAD system works. Here's my translation of all those funky radiology words. If you see a lesion described as anechoic, that means no echo. That's cystic or black, like we saw on the cyst in the picture. That's low risk. If you see the word hyperechoic, that means a lot of echoes. That's a white nodule. If you see the word hypoechoic, that's gray, meaning more risk. And if you see the word marked hypoechoic, that's what we consider as, and I know this sounds a little ridiculous, but it's very gray, and that's high risk. Okay, so anechoic, hyperechoic, hypoechoic, markedly hypoechoic. So maybe that'll help. So we talked about what are the adverse nodule features, and we said the first one was increasing size. So we're going to talk about that. To give you an idea on this points business, which is going to help us distribute the nodule in these different TIRADS categories, microcalcifications or punctate calcifications would equal 3 points. Taller than wide, also it's a big number of points, 3. Extra thyroid invasion, 3 points. If some nodule is described as hypoechoic, that would be 2 points, or very hypoechoic is 3 points, and solid is 2 points. Then they just might mention an abnormal lymph node, just another concern to worry about. So each of these adverse characteristics has a points given to it. So here's just some examples. For TIRADS 1 and TIRADS 2, we said that those are, on the benign side. The picture on the upper right, it kind of looks like a sponge. That's spongiform. So that's no problem. And the picture on the bottom is kind of has some black cysts and then some white stuff that's kind of crisscrossing in between. And that also, because of the characteristics of the cystic part, is not a risk. So those are very low risks, and we can dismiss these nodules as not a problem for us to worry about. Just to give you the actual numbers, let's look at the picture that was on the bottom, with the cystic and the other crisscrossing tissue. The actual points were on the composition. It had a mixed cystic and solid characteristic to it, so that's 1 point. And it was described as hypoechoic on the, or hyperechoic or isoechoic on the crisscrossing band, because it kind of looks like the other tissue that's next to us. So that only got 1 point. So this is a 2 point total, and that goes into TIRADS 2. So you can see that's how we get the points, and that's how we classify TIRADS. Okay, so I hope this is making a little more sense as to how the radiologist gives us the definition and the final report. Okay, this looks completely different, right? This nodule, where the yellow arrow is pointing, looks like it's solid, right? So just for being solid, you get 2 points on the composition. And because it looks kind of like similar tissue to the rest of the thyroid that's next to it, it would be isoechoic, and you get 1 point for that. So this is a total of 3 points. So if we go to the red box where it says 3 points and then the arrow going down says TR3, this would kind of depend on what is the size. If it's less than 2.5 centimeters, we're probably just going to be following that. And that might even be a nodule that we would just take and accept, whether you rate it or whatever. But it's only mildly suspicious, and it doesn't have any of the really adverse features that we were worried about, right? So at least something to consider, that's on the, more, I think I could do something with that kind of case. And let's compare that with this case, where it's a solid lesion. It's a little difficult to see with the yellow arrow, but there's a glob of something there and it looks fairly solid. And this is actually described as very gray. And when it's very gray, that's very hypoechoic. And you actually get a whopping 3 points for that. So you got 2 points for composition, 2 points for echogenicity. And then because it has the punctate calcifications, those white dots that look like little white islands or an archipelago of white spots, you get 3 points for that. So that puts it into a completely different area. That's 8 points for a TIRADS 5, highly suspicious lesion. So for all practical purposes, that's probably thyroid cancer. So even if you had a negative biopsy or an inconclusive one, with all those points, you're probably going to want to stay on the sidelines on that one. So just to reiterate, you can see from the upper boxes where I've highlighted in red, I've boxed in all the points that are, quote, available. for composition, echogenicity, shape, margin, and echogenic foci. And then I've circled in green, so that's the TIRADS 3 group. Depending on the size, you may want to take a shot on those. The TIRADS 4, which I've circled in yellow, also depending on size, but that's more suspicious of a thyroid cancer. So you probably want to weigh those carefully. Whereas if you have a nodule that's a TIRADS 5, that's pretty highly suspicious, and you probably won't want to make offers until you have a definitive answer on what is that nodule. Okay, so this kind of unleashes the underlying what's going on when you see a TIRADS number given to you on a nodule in a radiology report. So this kind of is a summary of those adverse features. So green, probably things that we can consider making an offer on. And that's when you have, lower number of points. Smaller is better than larger if it's cystic, spongiform, or white. So those are the low risk nodules. Yellow, the more concerning features, solid lesions, maybe a peripheral calcification, but also larger is worse. But those are kind of in the, we're not sure, maybe we could think about it, but it's not definite that we would make an offer. It kind of depends on how many suspicious characteristics it has. And then the top, the red, are the more worrisome features of a nodule. Microcalcifications, taller than wide, extrathyroid invasion, very gray or marked hypoechoic, irregular margins, and then it's worse if it's larger. So if you kind of keep this with you when you look at the next pathology or the ultrasound report, when you see thyroid nodules, this could be helpful. At the bottom, I just put coin size. You can kind of get an appreciation of, how big are coins? Like a dime is 1.79 centimeters. A quarter is more like 2.2 centimeters. So you can kind of get a feel for what is that, if you see a 2.5 nodule reported, it's larger than a quarter. So, fairly good size. And I put the Canadian coins as well, in case you use those. So we have a case. Now, let me warn you, this is a long case. So as I said, the radiologists are actually taught to only report the 4 most suspicious nodules. On this case, we have more than that. So either the radiologist wasn't following the guidelines or we just got lucky. So in this particular case, we have many nodules reported, which obviously that's a problem in itself, right? We'll look at nodule 1. The first nodule is 2 centimeters. It's reported as solid. You get 2 points for that. It's reported as hyperechoic. You get a point for that. So total of 3 points. It's a TIRADS 3. And the recommendation was, because it's 2.0 centimeters, or greater than 1.5 actually, it should be followed up in 1 year with an ultrasound. So you would have a decision. What should I do with that one? It's supposed to be followed up in 1 year. But you can still consider it possibly. Let's go to nodule number 2. Maximum size, 2.5 centimeters. That's pretty big, bigger than a quarter. It's also solid. It's also hyperechoic. That's 3 points. It's a TIRADS 3, but it's 2.5 centimeters. So the radiologist says, fine needle aspirate recommended or should be considered. So now we got a more worrisome nodule. So we got 1 follow-up, 1 may need a fine needle aspirate. Okay, how about nodule 3? 1.3 centimeters. Solid, isoechoic, that's 3 points. It's a TIRADS 3, but because it's smaller, it doesn't need to be followed up or biopsied. So, okay, we get a pass on nodule number 3. Nodule number 4, maximum size, 1.9 centimeters. Solid, isoechoic, that's 3 points. It's another TIRADS 3, but because it's 1.9 centimeters, so it's between 1.5 and 2.4, should have an ultrasound in 1 year. Okay, so far we have 2 follow-ups, 1 fine needle aspirate, I think, so far. Okay, nodule number 5. So we've already got to 5 nodules. You know, the radiologist is only supposed to report the 4 most worrisome. Here we go with a 1.5 centimeter nodule. Solid, 2 points. Isoechoic, 1 point. It also has macrocalcifications. You get an extra point for that. So this is a TIRADS 4 because it's 4 points. And it's also 1.5 centimeters. So that's a worrisome nodule. So number 5 is worrisome, should get a fine needle aspirate. So that's 2 that need fine needle aspirate so far. Okay, nodule number 6 at the bottom. This is pretty big, 3.2 centimeters. That's big. However, it had previously been biopsied and was benign. So they said, okay, don't worry about that one. It hasn't changed in size. Nodule number 7, also 3.5 centimeters. It also had been biopsied previously. So it wasn't recommended to necessarily follow up with anything particular like a biopsy. And nodule number 8, also large, 3.2 centimeters. It's cystic, isoechoic. You only got 1 point, so it doesn't need follow-up even though it's large. So, one more nodule. Nodule number 9, 2.4 centimeters. It was solid, isoechoic. You got 3 points. It's a TIRADS 3. It's 2.4 centimeters, so it should get an ultrasound. So we have kind of a mixed bag here. We have a couple that needed follow-up with biopsies and a whole bunch that needed ultrasounds within 1 year. So, you know, I would feel uneasy making an offer without getting, you know, something back on what the worrisome nodules were in this case. And there's so many darn nodules that you would wonder why they just don't take the person's thyroid out rather than continue to follow up on all these different nodules, especially if they've biopsied some in the past and then there may be new nodules popping up that look worrisome. You know, you'd want to know, like, why haven't we gotten the fine needle aspirate reports yet? And I might want to wait and see what happens on this particular kind of case. But you kind of get a flavor of, wow, some people can have a lot of nodules, and each nodule has its own risk characteristics. So that's a lot of nodules for one case. So I have a different case. Case number 2. This woman has a multinodular thyroid with a suspicious lymph node. She also has rheumatoid arthritis and is on an anti-TNF monoclonal antibody biologic for her rheumatoid arthritis. She wants to conceive. So this ultrasound report is much more difficult to wade through, but try to stick with me on what I've highlighted in the yellow, and we'll just try to hit the high points because everybody's probably kind of getting weary from all the long talking today. But anyway, it's described as a multinodular goiter. In the second bullet, there's a Thyroid's 4 nodule that's 1.1 centimeters, described as moderately suspicious. It's not large, but it has Thyroid's 4 characteristics which weren't really defined well. And this may have been done in a foreign country, so that's why we didn't get exactly all the Thyroid's characteristics described as we might in the US. In the third bullet, it's described as a moderately suspicious Thyroid's 4, but it's a small lesion. It's 0.2 by 0.47 by 0.48 centimeters. So that's a pretty small nodule, but it's still described as Thyroid's 4, which is worrisome. We're going to go to the rest of the report, which is on the next page. So there was also, and I didn't highlight this in yellow, but there was also a Thyroid's 5 highly suspicious lesion, but it was small. And the final recommendation was highly suspicious lesion. Follow-up is recommended. Obviously, we'd want to get a fine needle aspirate on that one because we wouldn't do anything without it. And then the other Thyroid's 4 lesion was also, it was recommended for follow-up. Well, this person actually did have follow-up and turned out to have papillary thyroid carcinoma with 2 lymph nodes involved. And so even small nodules, and that's why I presented this case, if they have adverse features, are worrisome. And so you have to pay attention even if the nodules are small. One last case. Applicant was a 34-year-old doctor who notices that his thyroid looks abnormal when he swallows. So he makes a self-diagnosis that he feels like he has thyroid nodules himself. So he goes to his doctor, who also feels multiple thyroid nodules in his neck. This was a while ago, so this was before Thyroids, and they used to use thyroid scans. So they would inject you with radioactive iodine 131, and the iodine would go to your neck, your thyroid. And if you saw a cold nodule, which means the radioactive iodine was not picked up by the nodule, that was an adverse feature. So he had one large 3.5 centimeter cold nodule. So that's bad. And he had other smaller nodules. He had a fine needle aspirate using ultrasound, which was inconclusive. And subsequently, he learned that as a young child, he had had radiation to his neck to treat swollen tonsils. So this has all the characteristics of a worrisome story. So these are the kind of things that you would worry about. However, we don't usually see nodules described this way anymore. But if you do ever see mention of cold nodules or, radiation to the neck as a young child with a large nodule like this, that would be a worrisome situation. Fortunately, this all turned out to be benign. So what are our takeaways today? So we have to evaluate each thyroid nodule on its own. And as I said, the radiologist may only do 4 nodules that are the most worrisome. So keep in mind, there may be some others that you're not so thrilled about either. And we use TIRADS to assess each of the nodules. Hopefully now you kind of have a better understanding of that, how TIRADS actually works. And if you can think about whether I could accept now and rate, or when should I pull the alarm switch. So your challenge, hopefully today, I know you've heard a lot of different ideas today, but hopefully there's at least one thing that I've said that you can take and in your unique way, make it useful when you see your next thyroid nodule case, which probably could be this week. But let our underwriting team know if we can be of help on any key cases. Maybe you have a key case that you're not absolutely sure which way to go, because we're here for you. If if there's any way we can help. And you can always refer back to these 2 slides that I gave you to help out. So we appreciate the 128 that hung on to the last, at least I do. And thanks for staying with us. And let us know if there's any way that I can help or the team can help you in any way. So TJ, I'm turning over to you.
Yes, thank you, Dr. J. And I think there was actually one question that came in. If there's any other questions, go ahead and send them now if you'd like. But on your first case that you had, there was a question about how do they determine which 4 nodules will be detailed? The size, as per your case, it seems that they look the size, but what if there is calcification on a smaller one node reported after the report?
Yeah, so what they would do is if any of the nodules look like a TIRADS 5, they would choose, report that one first. If that doesn't total 4, then you would go to any TIRADS 4, pick all those out, no matter what their size were. And then you would go to if there's any space left on the 4, you would go to TIRADS 3. So in other words, it's more ranked by TIRADS than it is size, although, as you mentioned in your question there, size may come into play, but it's probably more the adverse characteristics of each one of those as used in the ranking. Does that help?
Looks like it does. Thank you. Case number 3. When they did the, I'm trying to read here, it's kind of small in here, LT31, did they say that the iodine does not go through the cold nodule?
That's right. So in the cold nodule, let's see if I can get, in the cold nodule, it doesn't have pickup of the radioactive iodine. And what that means is it's not a functioning nodule. So that's what's scary about it, is it's kind of like out there on its own, not working. So you'd have to wonder, is that cancer because it's not really working like it's supposed to? So that's why the word cold was always a scary description of a nodule back in the good old days of I-131.
Perfect.
Hope that answers that.
Yes, and it doesn't look like we have any other questions at this time, but again, please feel free to reach out to Dr. Joannides or anyone on our team here, and we'll make sure to get those questions answered. Or as I said before, past couple of times, send any questions to info@optimumre.com, and someone from our team will get right back to you guys. So again, thank you, Dr. J, for a very informative presentation. Always great at explaining things on an educational purpose, especially for non-medical people like myself. So I really appreciate that, and I'm sure the audience does as well. So thank you again, and thank you to all the speakers today, Dr. Green, Anastasia, and Jill as well. And I don't know, Anastasia, do you have any closing comments you want to give as well?
No, thank you. I wanted to do exactly what you just did. Thank all the speakers. Thanks for the attendees, and looking forward to our in-person seminar in March. And yeah, that's it. It was a nice half a day to get educated and open our minds and see what's out there. And I think that we did well. Thank you for joining us. Jill?
Thank you, everyone. I appreciate it. We love it when you guys participate, and also just showing up. And if there's anything that you guys would like to hear about, just let us know, and we'll find either one of us or one of our colleagues that can give you some more information. Thank you. Have a good afternoon.
Yeah, and one last thing for everybody that's still around. We will be sending a survey out afterwards, so please fill that out because it does help us with future presentations. And as Jill just mentioned as well, and Anastasia, we will be having the in-person meeting on March 10th through the 12th of 2024. So more information will be sent out to everyone on that. And we'll also be continuing our webinar series in 2024. So stay tuned. But again, thanks everyone. And I hope you enjoy the rest of your week and have a safe rest of the day.
Thanks, everybody.
Thank you.
Thank you.
You.